So thank you so much. And we'll move on now to our next speaker, who spoke yesterday. So we welcome back Professor Schaper, who is a consultant endocrinologist in Maastricht and chairs the International Working Group Overall Editorial Board.
Good morning, everybody. My name is Nicolaas Schaper. I'm very happy, at least, to be virtually with you. I would have liked to have been to Malvern, a beautiful place, and this tradition of Malvern conferences set up by Andrew and now together with Jerry is a fantastic tradition. So I missed scones and the clotted cream, so I hope to be next time to be with you. And I was asked to give a presentation on the following topic, an overview of current therapies for diabetic foot ulcers. And that's quite a topic because it's a very broad subject. So I took the liberty to base my topic on the guidelines of the International Working Group on the Diabetic Foot. And there you can also find all the references to my talk. It's below on the slide. I have no financial disclosures. Actually, I wish I had. So if we talk about therapy of diabetic foot ulcers, of course, you have always to keep in mind that the pathway to ulceration and amputation can vary from patient to patient. And this, of course, is based on the work of Andrew Boulton. And you can see that it all starts with a combination, usually a combination of various factors. Neuropathy is usually there, together in many patients with impaired perfusion, the hypoglycemia, the biomechanical stress resulting in an ulcer with impaired tissue repair because the patient continues walking on the insensate leg or foot. And then if infection develops, in particular in a patient with comorbidities like heart failure, the risk of amputation is greatly increased. So there are different levels where you can intervene, either at prevention, I'm not going to talk about that, or at ulcer healing, at restoring tissue perfusion. We can't, unfortunately, restore neuropathy. At lowering biomechanical stress. If there's continuous stress on the ulcer, of course, it will have difficulties to heal. Or if you're in the next phase, try to prevent amputation by treating infection and other comorbidities that impair wound healing or greatly enhance the risk of amputation. In the Eurodal study already, 20 years old, we showed that it's one of the largest studies, multi-center studies in Europe. We showed that nearly all the patients had neuropathy. That was not new, but up to 50% had also peripheral arterial disease, PAD. And please note that at presentation, already half of them were infected. Half of them were thereby clearly at risk of amputation. So infection, if you make a list of priorities, I would say is the first one you have to address because that's an immediate threat to the limb. So you should always perform a direct debridement. And if you can't do that, then take care that the patient is sent to the clinic where a debridement, immediate debridement is available. Because you should do that to assess depth and severity, because usually there's a lot of callus, debris, dead tissue, and you can't just assess the depth of the ulcer. You have to use a knife to clean the ulcer, to clean it, to remove the callus, to remove the pus, and then with a sterile instrument, you could probe the ulcer and to see if you go into, for instance, into a joint or into bone, because you can't see that, you have to feel that. At the same procedure, you already start to evacuate pus if there is a large abscess. Of course, that's not the final solution, but at least you can remove the pressure, you can open the infected compartment, and you can start removing that tissue and callus. In particular, if you have a superficial ulcer, that will be sufficient in many patients. So the treatment of infections actually starts with surgery, which maybe is a bit strange from an internist. And the treatment, subsequent treatment of infection depends on the grade of infection. And we use for that the International Working Group classification or the ISA classification. And we say you have mild infections if there are more than 2 or more signs of local inflammation. So it's a local infection. A moderate infection is more extensive redness and involvement of tissues deeper than skin. So we call an osteomyelitis a moderate infection. So we usually say moderate infection with or without osteomyelitis because that affects treatment. And then you have severe infection with the criteria mentioned here. If you classify each of these infections based on this classification system, you immediately have an idea of the risk for future amputation because that increases from mild to severe. And it also facilitates communication between healthcare providers. And finally, it helps you to choose your antibiotic once you have debrided the ulcer. And the initial antibiotic therapy after immediate debridement should be in a mild infection flucloxacin or cephalexin. The moderate infection, usually we treat with amoxiclav or with a drug that has better bone penetration. If you think that there might be an osteomyelitis, like ciprofloxacin or clindamycin or clindamycin, and severe is shown here. Of course, this is in case of no allergy, no recent antibiotics, and this is a scheme we use in my hospital based on the guidelines of the International Working Group. There are also other schemes available, but it starts with simple, small spectrum antibiotics with mild infection and then gradually broadening the spectrum. Before you start your antibiotic treatment, of course, you have to obtain a specimen for culture because I just talked about initial therapy. So after 2 days or 3 days, when you have the results of the culture, you can tailor down based on the results of the culture. And that culture should always be either tissue, pus, or corretment material obtained after debridement of the base of the ulcer. And if you have a deep ulcer with a fistula, you could use a deep swab technique after, of course, debridement. But please, no superficial swabs. In France, they did a beautiful study where they banned the use of superficial swabs from the first aid departments, and the number of microorganisms cultures was greatly reduced because if you do a superficial swab of an infected ulcer, you get a whole bunch of bacteria which are not the causative microorganism, which are not the microorganism invading the tissue. So you should go for tissue. And that study in France showed that they could reduce the use of broad-spectrum antibiotics and reduce costs. And of course, never culture or treat an unaffected ulcer. So how long do we have to treat? Well, duration and route of antibiotic and mild infection, 1 week oral with a small spectrum is usually enough. Moderate, usually 2 to 3 weeks in case of soft tissue infection. And of course, in case of osteomyelitis, longer, usually 6 weeks. But recently a study has been published of Gariani and showing that actually with 3 weeks might be sufficient if you have no dead bone. We still stick to the 6 weeks, but that study showed that we are treating osteomyelitis in shorter durations more progressively. And you should probably could start with oral immediately, although the evidence there is again weak. So usually many people start after 2 or 3 days with oral therapy if you use an antibiotic which has very good bioavailability. And severe infections, treatment is usually longer, 2 to 4 weeks. And of course you start immediate intravenous therapy. Consider longer duration in peripheral arterial disease or extensive infection. And that's of course where you use your clinical judgment. So that was infection. The second immediate threatening problem for the limb is of course peripheral arterial disease. And you have to ask yourself a series of fundamental questions. Is there PAD? We're not going to address that. Who to revascularize, when to revascularize, and then, only then, how to revascularize. Well, factors influencing the choice of revascularization are, of course, the severity of perfusion deficit, but it's not only that. You can have moderate impaired perfusion, but with a very large ulcer or with a lot of necrotic tissue, then the threshold to perform revascularization should be lowered. The same applies for infection. The combination of infection and peripheral arterial disease is more than double trouble. Of course, the location of the ulcers. Heel ulcers are more difficult to heal. So in our center, we treat them more aggressively. And of course, don't try to improve perfusion in a leg that can't be saved. And finally, there are two other factors: the chance of technical success, and of course the risks of the procedure, because we talk about frequently very frail patients. Your aim to restore tissue perfusion should be to facilitate wound healing, to limit tissue loss, to enable amputation at the lowest level, but to have a functional leg. You could use for that the WIFI classification. The WIFI classification is a nice system that at least combines certain dimensions of the ulcer and the foot and helping you to make that choice. Is there an indication, and what are the risks for amputation? And you take into account wound characteristics, infection grade, and assessment of severity of the perfusion deficit based on ankle brachial index, toe pressure, and or TCPO2. And then you can revascularize according to risk stratification and expected benefit. There is an app for that, and you can simply download it on your mobile phone. And at least in my center, many vascular surgeons have this system. And the nice thing is that it combines different aspects, and it uses, for instance, the International Working Group infection classification system in order to assess risk of amputation. You should try to direct your blood flow to one or more foot arteries, preferably to the anatomical region of the ulcer. And after the procedure, you should do objective measurements of perfusion. And this does have implications. I'm not going into details here, but if you do an endovascular treatment, it's frequently they open up a vessel and they say, okay, it's done. But it's not opening vessels, it's restoring perfusion in the region of the ulcer. And that sometimes has major implications of the complexity of your procedure. I should discuss that with the people who do the revascularization. And if you do open, so bypass or endo, that depends on individual factors and of course of expertise in the center. But we clearly stress that if you treat a patient with a foot ulcer, and that patient has a chance of having peripheral arterial disease, and that's 1 in 2, 50% in Western countries, you should always have the facilities to diagnose peripheral arterial disease and to revascularize such a patient. And if not, I think you should not treat the patient, but send it off. Offloading, that's central. Once you've restored perfusion, once you've treated infection. I can't go into detail very much, but of course, if you keep putting stress on the ulcer, it will hardly heal, or it will take many times to heal, many weeks to heal. How to offload? Well, you can find that in our guidelines. This is a slide made by Siko Bas. There are many different techniques, but the most important message is that please use, if possible, and with possible I mean if there's not a high-risk patient for complications. For a plantar ulcer, always use the plaster or at least a knee-high offloading device, and there are different devices for non-plantar ulcers. One of the probably most important parts is, besides using a plaster or a walker, is that you should make it non-removable. Here you can see a beautiful study of David Armstrong showing that he had healing rates of plantar ulcers of nearly 90% in the observation period. And of course, the plaster was worn 100% of all steps, he put a pedometer in the plaster. But if you give a patient a removable plaster, despite intensive education, his patients only wore the plaster 27% of all steps taken during the day. 27%. So they remove the plaster once they're at home. And of course that results in very poor healing results, only 50%. So if you use a plaster, and you should use a plaster or a walker in a plantar ulcer, if there are no contraindications, then always make it non-removable. Wound treatment, well, that's a very complex area, but it's based on frequent debridement. Use a simple inert sterile gauze or foam. Always treat edema, and sometimes you need a dermatologist for that because there is venous insufficiency. In deep ulcers, you could use negative wound pressure. If you have poorly healing wounds, despite this optimal treatment, you could consider placental-derived products. I have no experience there, but there is clearly evidence for that. And if you have poorly healing neuroischemic ulcers, you could consider ErgoStart or Leucopatch. Very innovative new approaches, which in very well performed trials has shown efficacy. But the downside is there, as far as I know, each of these products was only studied in one trial. So we need a bit of more evidence there. But there is also indirect evidence for the efficacy of Leucopatch. And you should always consider in large defects plastic surgery. Then there, of course, is the problem of the topic of oxygen. The guidelines say that you might consider hyperbaric oxygen in certain circumstances. I never use it. And there is recent evidence that topical oxygen might work, but there again, we probably need a large enough trial showing efficacy. So the cornerstones of treatment are restoration of perfusion, treatment of infection, the offloading, wound treatment, treatment of comorbidities, I didn't mention that, and energy malnutrition. Jan Appelquist has shown that quite a large percentage of the patients he treated in his center had signs of malnutrition. You should, of course, educate the patient, but not only the patient, also family and healthcare providers involved. And you should organize your team in a closely collaborating team. So organization of care in a closely collaborating team. And that team should extend from primary care into secondary care and, if necessary, tertiary care. Because if you don't connect these different elements in your center or between your center and primary care, you end up in problems. And that has been beautifully shown, for instance, in England, by Wise in 2016, based on an audit, that patients who were referred later had poorer outcome. And very recently in Italy, it was shown by Maloney that the risk of a major amputation is 50% higher, 48% to be exact, in patients who were referred late. And once the patient is treated in a multidisciplinary diabetic foot team, that is probably associated with also a 50% reduction of major amputations, as shown in a very recent meta-analysis. And a more qualitative study, which I like very much, shows that one of the important aspects of that multidisciplinary team is the presence of a captain. And in my personal opinion, it doesn't matter who's the captain. It could be a surgeon, it could be a physician, it could be a specialized nurse, but as long as there is one person who is the gatekeeper and who takes care of quality control and other aspects. So organize your team, create a captain, and reach out to primary care. But that's not all, because we put a lot of emphasis on saving the leg. But actually, 50% of the patients will be dead within a few years after you've treated them. And already some older evidence obtained the last 10 years showed that if you do aggressive cardiovascular risk reduction treatment in these patients, treat the lipids, treat the glucose level, blood pressure, and in the presence of peripheral arterial disease, give them thrombocyte aggregate inhibition, so antiplatelet drugs, etc., you can clearly improve their outcome. So that's why I put this slide as in the end. Don't just think about saving the leg, but please also think about saving your patient. It was a bit strange to give this presentation virtually. I would have loved to be with you in beautiful Malvern, but that unfortunately was not possible. So I hope to see you next time, and I would like to thank Andrew and Jerry very much for inviting me, and I would like to thank you for your patience in hearing my lecture. Thank you very much.